Welcome to Sacroiliac and Pelvis Anatomy Review Part 1. This is a 10-minute video which we will request participants of the Hesch seminar to study prior to taking the seminar. And we are the Hesch Institute in a clinic near Las Vegas, Nevada, actually in Henderson, Nevada. And these are the PowerPoint slides that we have utilized to give a general overview, particularly regarding the pelvis and the sacroiliac and its integration with the hip joints and pelvis, lumbar spine. So we'll talk about pelvic landmarks, joint characteristics, axes of motion. And anatomy and motion are typically appropriately taught together. You may be familiar with a seminar and a biomechanical principle that when the foot hits the ground everything changes, and that's so very true. There is in fact a reflex in the subtalar joint that when motion occurs there, on heel strike, the upper cervical spine rotates in the same direction. Now, welcome to our seminar, which is when your behind hits the chair, everything changes. And this is kind of a humorous perspective that human function happens in many ways, not just walking, running, dancing, but also sitting, lying down, turning, twisting, etc., etc. This is taken from Kapanji's books, and this demonstrates the primary curves in the spine. On the left is a sagittal view, and then a dorsal view on the other side, and when you alter one of those primary curves, of course the other curves are affected. One of our principles is to look at the lowest denominator of an injury, and this helps put that into perspective. He also likens the spine to a mast of a ship, and of course if there's some unleveling on one side, it not only affects the body on that side, but on the opposite side throughout the whole body. There was a fluoroscopy study of the sacroiliac joint done by an orthopedic surgeon, and this was done looking at the SIJ with fluoroscopy while multiple forces were put through the pelvis using the traditional pain provocation tests, direct thrusting on pelvic landmarks, and it showed absolute compression and release, compression and release, compression and release of the joint, which spoke very clearly to me that the important concept was that motion moves through the SI joint much more than motion being isolated specifically in the SI joint, which is certainly very, very difficult to do in the clinic to specifically evaluate it and specifically treat it, although we elaborate on that later on. So typically there's less than 2 degrees of rotation on one SIJ, typically less than 2 millimeters of glide. There are some exceptions. Of course there are a pair of sacroiliac joints and a symphysis pubis, so total motion is greater than that. And certainly in the peripartum and postpartum states the pelvis is much more mobile, and so motion can be much greater than that, and some people do sustain trauma such that their motion is certainly much more than that. Motion is triplanar, and the main concept is that the joint properties allow for 6 degrees of freedom in the pelvis. Now if we talk about the bony pelvis, we have to agree that motion of the pelvis as a unit is much greater than motion inside the sacroiliac joint. And there is a lot of misconception with the belief that you can palpate the pelvis, and if the pelvis moves asymmetrically, that motion is coming from the sacroiliac joint, and that is absolutely untrue. There might be a very, very small motion in the SI, but the pelvis moves as a unit, and in weight bearing, the SI joints are compressed. Therefore, they are very stable. Therefore, they do not move during gait. There may be the most minute shock absorption, but mostly it acts at that level as a force transducer, a locked force transducer. And you can look at studies that demonstrate large excursions of pelvic landmarks, while motion studies of the SI joint with the same functional movements reveal very, very minute motions. And that's a very, very important concept. Unfortunately, there's a lot of marketing ongoing in the public domain, especially on Facebook, and even some clinics across the country that promote the archaic belief that the SI joint moves a considerable amount. It does not. So motion of the pelvis is much greater than the SI, and it's measured in centimeters of glide and in large degrees of rotation using double digits. And we can talk about the different terminologies of gross pelvic motion, and depending on which book you look at, if you want to contrast joint structure and function, the hip chapter, if you want to contrast that with a book on kinesiology. Donald Newman is an excellent book on kinesiology. Levangie and Norkin is a very good book on joint structure and function. You'll find subtle differences in the terminology of gross pelvic motion. You can look at any chapter on gait and you will find specific terminologies. And what's important to do is to bridge that with the terminology of people who describe so-called sacroiliac joint dysfunction. So we have to understand what each party is speaking of, and we have to understand from the research and truth what is really happening. So we won't spend a lot of detail on each specific terminology, but the pelvis moves in three-dimensional space in multiple directions. This is a view that you are probably familiar with of a spinal motion segment, and there are three axes: vertical axis, up and down, medial lateral axis, and an anterior posterior axis. So the motion segment can glide forward and backward on that axis. It can glide up and down or left and right. It can flex and extend on one axis, side bend left and right on the other, and it can rotate left and right on the third axis. You could use computer modeling, and no matter how complex motion is, you could bounce a child's block around the floor and have it bounce off the furniture, and you could evaluate every location in three-dimensional space, every moment, every second, or whatever time frame you're looking at, and you would analyze it in three planes of the body, three cardinal axes. So it's important to look at the whole pelvis. How does the whole pelvis move in three-dimensional space? And it moves with the hips, it moves on the hips, it moves with the trunk, with the lumbar spine and rib cage, etc. The actual SI motion occurring during this gross pelvic motion is so very minute, typically less than a millimeter of glide, less than 1 degree of rotation. There are some very, very rare exceptions. Now this is a inside view of the left hemipelvis. So what we have here is the articular cartilage on the ilium, which is hyaline cartilage. So the PSIS is right here. Here's the iliac shelf, and here is the ASIS. The pubic joint is right here, and the ischial tuberosity is down here. So notice that the SI joint is elongated on the bottom, wider and not quite as long on the upper arm, and that it's somewhat like a boomerang. And of course everyone has a slight different alteration in the pelvic angle, but basically it looks like a boomerang pointing downward. Okay? It's an important image to keep, to know. Now this is a view of the sacrum with respect to the three cardinal axes, and this is the facets that articulate with L5. And important landmark here is the inferior lateral angle, and these bumps and grooves have all kinds of different names, different terminologies from the lumbar spine, which makes it a little bit confusing, such as intermediate, medial crest, intermediate crest, lateral crest, etc., etc. It's good to look at the pubic structure in terms of moving in three-dimensional space about 3 cardinal axes, and that would be each pubic bone connected by the fibrocartilage, or one pubic bone, and the fibrocartilage as though it could move independently, or at least it's mobile and it is connected to the pubic bone. So it's good to look at it from each of those perspectives. This view shows forces going from the upper body down, going through the SI, down into the hips, and forces coming from the ground up, such as in weight bearing or heel strike, and the forces go up through the SI into the upper body, going through the hip joints, and part of that forces goes through the symphysis pubis joint and compresses the upper part of the pubic joint. Here is a look at the body in the frontal plane, and of course the whole pelvis, looking at it from an anterior view in the frontal plane, and of course the left hemipelvis here. The acetabulum that houses the femoral head, the true hip joint, is right here. This is the pubic bone here, and then in purple is the ischium, and then this is the ilium, and collectively some people call that the hemipelvis. Some people call the hemipelvis the ilium, but in truth the ilium is, pretty much the upper half of that pelvic bone. So it's good to know what one's terminology is when they're speaking of the anatomy. The best terminology would be to call this the left hemipelvis, to call this portion the pube, this portion the ischium, this portion the ilium. And this is a posterior view. Sacrum here, of course. PSISs are right here. Now this long ligament here is the long dorsal sacroiliac ligaments. Inside here are shorter fibers, shorter sacrum to ilium ligaments. This long, expansive, very wide, strong ligament is the sacrotuberous ligament, important to palpate during evaluation. Notice this lateral ligament inserts partially on the coccyx, partly on the sacrum, which is the sacrospinous, and that's a little tricky to find. This sacrotuberous is much easier to find, and if you go at midpoint lateral to the ILA, inferior a little bit, you can then palpate the distinct fibers of the sacrospinous ligaments. And then here is a similar view, and this shows that in about 30% of the population, the long head of the biceps will bypass the ischial tuberosity and actually insert directly on the sacrotuberous ligament. Alternately, it'll blend and insert on the ischial tuberosity, but also on that ligament. So we have a significant muscular influence on muscle tone, and study by Vleeming and his colleagues has shown that that can influence SIJ motion, again talking very, very small amounts. Here's an anterior view of the ligaments, the iliolumbar ligaments, the anterior sacroiliac capsule and ligament, which is quite thin. There's also an anterior lumbosacral ligament, which is not visualized here. Here's another view of the sacrospinous, because it goes from the ischium of the spine of the ischium rather, to the sacrum. See how broad that is, and look at how broad the sacrotuberous ligament is as well. We'll get to the pubic ligaments later on, and this is simply another view of the same. And one study did show that cutting the iliolumbar ligament does enhance mobility of the SIJ. So sometimes when people have surgeries where they extract bone posteriorly, such as a spinal fusion, that will enhance the SI mobility somewhat. So we're going to stop here. I probably went just a little bit over 10 minutes, and we will resume with part 2. Thank you.